We will continue the prostate cancer part 25C, inhibitors of androgen synthesis. Ketoconazole. Mechanism of action of ketoconazole is competitive inhibitor of several cytochrome B450 enzyme, including 11 beta hydroxylase and CYP17 complex that contains 17 alpha hydroxylase and CYP17 and 20 lyase. Inhibition of CYP17 reduces synthesis of androgen in the adrenal gland and the testicle. Inhibition of 11-3 hydroxylase reduces synthesis of aldosterone and glucocorticoid in the adrenal gland. Therefore, supplementation is important in patients with ketoconazole. Thus, glucocorticoid mineralocorticoid replacement is recommended when using ketoconazole. Castration or castrate level of testosterone might occur by 8 hours after 400 oral dose. The effects are dose dependent. Testosterone is diminished within 800 milligram per day and eliminated with 1,600 milligram per day. Side effect: hepatotoxicity, weakness, lethargy, nausea, vomiting, decreased libido. The dose-limiting side effect: nausea and vomiting. Adult dose ketoconazole 400 milligram per oral TID. TAPS is 200 milligram as you see previously. With steroid hydrocortisone 10 milligram TID, prednisolone 5 milligram per oral BID. Side effect might be reduced by starting ketoconazole at 200 milligram TID and increase the dose to reach 400 milligram TID as tolerated. Require stomach acids for dissolution and absorption. Therefore, give all gastric acids blocker 2 hours after ketoconazole dose. If ketoconazole decrease warfarin metabolism, avoid use with a hypoglycemic agent or severe hypoglycemia. Ebrotron, that's Zytiga. Both ebrotron and ketoconazole inhibit CYP17, however, they differ in the following ways. Ebrotron is a selective inhibitor of CYP17, while ketoconazole non-selective inhibitor of several cytochrome complexes, including CYP17 and 11B hydroxylase. So ebrotron is selective, ketoconazole is non-selective. Ebrotron is a potent inhibitor, but ketoconazole is weak inhibitor for CYP17. Ebrotron is irreversible inhibitor, but ketoconazole is reversible competitive inhibitor. Ebrotron increases aldosterone because it inhibits only CYP17, while ketoconazole decreases aldosterone because it also inhibits 11B hydroxylase. We come to the aminoglycosides. Mechanism of action: block transformation of cholesterol to pregabalin by inhibiting cytochrome B450 enzyme called CYP11A1, also called B450 SCC, which reduces the sensitivity of glucocorticoid, aldosterone, and androgen. Thus, glucocorticoid mineralocorticoid replacement is required when using aminoglycoside. This medication is largely of historical interest, is typically not used anymore. Side effect: hypotension, nausea, vomiting, fatigue, anorexia, depression, edema, skin rash. Adult dose aminoglycosides 250 milligram per oral UID 6 hours. Prolactin antagonist. Mechanism of action: block prolactin secretion by the pituitary. In those who are not longer responsive to standard hormone therapy, this agent can relieve symptoms, especially bone pain. Example: bromocriptine and levodopa. This is known as prolactin antagonist, and is block action of prolactin secretion by pituitary. This no longer responsive to standard hormone therapy. This agent can relieve symptoms, especially bone pain, example bromocriptine and levodopa. 5-alpha reductase inhibitors for the treatment of the prostate cancer. The NCCN guideline states that there is no proven benefit for adding 5-alpha reductase inhibitor to the standard androgen deprivation. In general, use of 5-alpha reductase inhibitor to prevent progression during surveillance of prostate cancer is not recommended, but the REDEEM trial randomized men with low-risk prostate cancer CT1 to T2 Gleason score of 5 or 6, PSA less than 11, or placebo to the placebo, or dutasteride milligram, 0.5 milligram per oral QID. Follow-up 12 core prostate biopsy were performed at 18 to 36 months. After 3 years, dutasteride did not alert the progression to lesion grade 4 to cancer, compromising more than 50% of the tissue in positive core. Dutasteride appeared to reduce the risk of having more than 4 core involved within cancer, but the difference was not statistically significant. This study was underpowered and could not adequately assess the pathological endpoint. However, retrospective data with long-term follow-up suggests that 5-alpha reductase may reduce pathological progression during surveillance. A non-steroidal anti-androgen. Mechanism of action: anti-androgen inhibit androgen receptors. They prevent the binding of dihydrotestosterone or dihydrotestosterone and testosterone to the androgen receptor. Androgen receptor in the pituitary and hypothalamus are also blocked, which prevent androgen from engaging negative feedback and lead to increased serum level of luteinizing hormone. Thus, the adrenal and gonadal androgen production actually increases. Libido and potency are preserved because testosterone is not reduced. Excess testosterone may be converted to estrogen by aromatase, which is in the aromatase, which in adipose tissue, resulting in gynecomastia. First generation anti-androgen like flutamide, bicalutamide, and nilotamide. Flutamide is known as uloxine. Flutamide half-life 6 to 8 hours. Adult dose is 250 milligram per oral TID, caps 125. Also available. Side effect: hepatotoxicity, gynecomastia, diarrhea, nausea, vomiting. GI side effect are dose-limiting factors. Bicalutamide, Casodex. Bicalutamide half-life approximately 5.8 days. So have long half-life compared with flutamide with half-life of only 6 hours, known as Casodex. The bicalutamide is 50 milligram compared with flutamide, it's 250 and 125. Just bicalutamide or Casodex is 50 milligram. Side effects similar to the flutamide but less gastrointestinal effect. Nilotamide, known as nalmudronate or nalandronate. Nalandronate, nilotamide half-life, it is 45 hours. Also have a long half-life than flutamide. Flutamide is only 6 hours, 6 to 8 hours. This is 45 hours compared with bicalutamide. It is 5.8 days. Adult dose of nilotamide or nilandronate, it is 300 milligram per oral QID for 3 days, then 150 milligram daily day after. So for 30 days, we can use 300, then 150. Side effect: visual disturbance, alcohol intolerance, rarely interstitial pneumonitis, nausea, vomiting. Second generation anti-androgen include enzalutamide, evolutamide, and darolutamide. Steroidal anti-androgen, mechanism of action binding to DHT and testosterone to the nuclear androgen receptor, inhibit 5-alpha reductase, and has negative feedback on hypothalamic pituitary axis. Side effects include weight gain, example, megastrol acetate, megas, or cybrotron acetate. Cybrotron is not available. This is the end of part 25C. We'll meet again in part 25D.